Welcome everybody to what is the 8th session on rehabilitation in conflict in this webinar series that's hosted by World Physiotherapy and supported by a wide range of rehabilitation organizations from around the world. My name's Pete Skelton from WHO. My job is simply to walk you through the administration of the meeting today, and then I'm going to hand over to World Physiotherapy. Just to highlight where we're at the moment, we're kind of on a midweek session at the moment on the fracture in conflict, and then we're off schedule again next week. So the next session will be on Thursday, the 21st of May, on peripheral nerve injury in conflict and hosted by the World Federation of Occupational Therapists. I'm now going to hand over to Chloe, I believe, from World Physiotherapy, who's going to give a short introduction to the session. And then we'll be handing to colleagues from ICRC and other organizations for the clinical content. Thank you very much.
Thank you, Pete. Hello, everyone. Thank you so much for joining us today for the Rehabilitation in Conflict Settings webinar series. My name, as Pete mentioned, is Chloe Martin. I'm the Senior Marketing and Communications Officer at World Physiotherapy. Also, as mentioned, this series is being delivered in partnership with the World Health Organization, by World Physiotherapy, and in collaboration with global humanitarian organizations, including the International Committee for the Red Cross, who are joining us today to discuss the extremely important topic of fracture in conflict settings. Without further ado, I will now hand over to Verena Kreiliger-Young, who is a global hospital physiotherapist with the ICRC, and who will introduce our other speaker today and lead us through the session. Thank you, Verena. Over to you.
Thank you very much, Chloe. I'm just going to share my presentation. Can you see my screen?
Yes, we can.
Thank you. So good evening, good afternoon, everybody. My name is Verena Kreiliger. I'm the Global Hospital Physiotherapist for the ICRC Hospital Projects. I will co-presenting today with my colleague from the Rafah Field Hospital in Gaza, Dr. Niveen Nahid. We will share their presentations. I will do the start and then we will hand over to her. So today we are going to talk about the very important topic of fracture management in conflict. As we have heard throughout all the other presentations already, in conflict, we don't have only one problem by itself. We have a multitude of injuries often which we have to cope with as rehabilitation specialists. So today, the aim of this webinar is that when we're working in disaster and conflict, we cannot always provide the treatment we would in contexts where there is high resources and high capacity. So in conflict and disasters, we need to focus on the best care possible, and it is not always what is the highest standard and what is recommended in the literature. We need to be prepared and we need to have training in the key areas. So preparedness of each professional, so each professional knows their role in the emergency setting, and this means mainly in the mass casualty and mass casualty response, which is often what is happening. So in conflict settings, we have a high demand and a high request for triage to optimize the health professionals' involvement. Physiotherapy participants physiotherapy participates and ensures that the hospital is a safe place for the patients and that patients can be safely discharged. I think one thing which is very important, we have people from across all contexts, and we need to, as health professionals or as rehabilitation specialists, we need to ensure that we work within the framework of our context and of our country. I mention this in specific because there is contexts like Iraq and Lebanon where physiotherapists are not allowed to apply plaster of Paris management for fractures. And that is one of the techniques we use quite frequently in conflicts. So today we're going to talk about fracture and fracture management. I would like to put a disclaimer. I'm a physiotherapist. Dr. Naveen is also a physiotherapist. So we have no surgeons on the team presenting today, but the presentation has been put together with the help of surgeons, nursing, MHPSS specialists who have put their input into it. We will talk about adapted clinical management for surgery, nursing, and medical MHPSS, as well as rehabilitation context. We will specifically look at the management of fractures with plaster of Paris, as I mentioned before. We will mention traction and external fixation, as well as complications, challenges, and important considerations. Now I would like to ask Chloe to launch a poll. I would be very interested to know if you, the participants, are actually working in active conflict zone at this point in time. All right, while we will continue with the poll, answers are still coming in. I just want to talk a little bit about fracture management generally. So when we have fractures in conflict settings, as I said before, we want to do the best treatment possible. And we want to encourage a maximal function post-fracture recovery. This can be achieved by promoting interdisciplinary work. So it's quite important we work as a team quite closely together. And we must ensure that we have the competencies related to the management of fractures. With plaster of Paris, if that is applied by physiotherapists, that we know how to work with external fixation and with traction. Including patient care and information is very important. So the family and the patient and the carer need to be involved in the rehabilitation. As rehabilitation professionals, we also need to ensure that we know when to seek support and when we ask the service user to come for proper follow-up. So that's the interdisciplinarity is a very important part of the treatment. I think I will stop the poll now. Do I stop the poll or do you stop the poll, Chloe?
I've stopped that. I'm sharing the results. Hopefully you should be able to see it, attendees
Yes.
as well.
Okay, so it's really interesting. I can maybe just quickly speak to that. We have about 34% of the participants who are actually working in active conflict zone at the moment. And we have 66% of the participants who are interested in the topic. And I presume this is because you're interested to work in conflict zones or because you want to get ready and prepared. So thank you very much for that participation. In conflict and in disaster areas, we have fracture is the highest percentage of the injury we see in these situations. Typically, the majority of the fractures will be in the lower limbs, so in the legs, and some of them will be in the upper limbs, but it is plus or minus 80% of cases in the lower limb. One very important distinction between normal fracture management and fracture management in disaster and emergencies or in conflict zones is that we very seldom have closed fractures. As I said at the beginning, the majority of fractures are one of the injuries, and we have often associated injuries such as we have heard before, like TBI are very common, burns are very common, so we often have very complex soft tissues injuries, which we have to negotiate at the same time as we have to try to ensure we get the best alignment for the limb and the limb fracture. The fractures are mostly comminuted, meaning they're complex fractures. You've seen the picture in the second slide, where there is lots of different bone fragmentations, and it's very seldom that we have simple fractures. This is because of the trauma and the way the fracture happened. So polytrauma and multiple fractures are more common than simple fractures. Also, very frequent are involvement of nerves or vascular involvement as well, which can have a big impact on the long-term outcome, as well as soft tissue, as I just mentioned before. We need to consider that wounds, open wounds with fractures, are very dirty and very contaminated, and therefore at hugely high risk of infection. And the importance here is that while fracture is a very important long-term potential, if it's badly managed, long-term problem, a patient will not die necessarily of a fracture if there is no nerve or vascular injury. So if we think about the first management of a patient arriving in a hospital with a fracture, the fracture immobilization is secondary to the wound and also secondary to ensuring that the patient is not bleeding to death. Once the soft tissue and the additional problems are dealt with, we know that for successful bone healing, an early weight bearing is essential. So that's where physiotherapy comes in as well. I will now, so the adaptive clinical management for surgery in low resource settings has the aim to bring the best care possible in the given context. And it's not necessarily the best care described in academic literature. Tractions versus internal fixation. The fracture management must respect the local standards and procedures. So I refer here as a comparison, the Lebanese example, where physiotherapy is not allowed to apply plaster of Paris, versus the Yemen or the Gaza context, where it's the physiotherapist who does the POP management. Very crucial from a surgical side, in particular, well, in open fractures and in crush injuries, is to assure that there is very good debridement done before providing any definite fracture management. So as I said before, the more important part, or the very important and crucially important initial part of the management of the patient is to ensure that the wound is really well debrided and there is no risk of infection before we actually deal with the fracture. I will now hand over to Naveen. Naveen, please.
Yes, thank you, Verena. Good morning, good evening, good afternoon for all. Hello, everyone. I'm Naveen Nahid Yassin, physiotherapist, work team leader in ICRC, hold master degree. Really, I would like to share or open start video, but because it's a poor connection here in Gaza, as you know. So I will start to explain. Here we will explain how fractures are managed in different settings, especially in emergency situations like in field hospital or places with limited resources. So the idea is not to do the perfect care. It's just to do the best possible care. So, in the treatment for a closed fracture in high resources setting, mostly we used internal fixation and like a plate and screws. And it can be also treated conservatively by BOP or traction and X-fix, especially in conflict, and maybe also used in high resources setting, especially if the closed fracture it's not complicated. In reality, there are most fracture open, not the closed fracture. It's related to the mechanism of injury. Most of cases come with explosive injury and blast injury, exposure to dirty water. It's also could increase risk of contamination and poor theater condition and contaminated hospital environment. So we need to think here about infection, which is a major complication in open fracture. So we use in the open fracture, we never use or treated by BOP because it's considered as cause of infection and contaminated. In the femur fracture, either it's closed or open, the traction might be used in a limited resources setting like Gaza to start realign and help bone healing. And it's also give like access direct for COD or change of dressing. Here in the fracture, we see a lot of cases with like complication, serious complication, and the physiotherapist should be aware about it and have trained and very well knowledge about red flags like compartment syndrome. So in compartment syndrome, we should discover it or detect it as soon as possible, especially to see 5 B's symptoms of it, pain, paresthesia, and pallor and cold of the limb. So our rule as physiotherapist in emergency or conflict situation, we should discover it and immediately told the doctor. So immediate surgical intervention like fasciotomy, it's very essential to relieve pressure and save the limb from the amputation. Next, Verena, please. Okay, in this slide, we will explain how importance of nursing care and how to do a proper dressing technique and how to follow as much as possible IBC principles. So as we said, the mechanism of a blast injury and contaminated hospital and bad hygiene or environment, it's increased the risk of contamination, especially as we said in open fracture. High risk of infection, so the proper wound care include a clean wound and sterile dressing change, monitoring for redness and any another symptoms like pus or fever, bad smell from the wound. Next point about assess in neurovascular status. We should take care about a neurovascular symptoms like skin color, and we should notice blood supply, skin temperature, circulation, and also test sensation and motor and pulse. And about management for edema and prevent pressure source. We should follow instruction for the patient, and it should be like a clear instruction, and to use what is available and advise him to elevate and the proper positioning, and if it's an upper limb to use a sling, and encourage him for mobility and early mobility and ambulation. Also, we can monitoring circulation and prevent the pressure source by reposition the patient regularly and keep skin clean, and we can advise him to use mirror to check the pressure point and to keep the area dry, and also to use cushions, soft support surface, and if possible, air mattress, but it's not limit the patient to go out from the bed. We encourage out of the bed, but during the bed, he can do exercise and use something available like gloves with water to prevent any bed sores, or even normal saline bags. We use it in field hospital. And also we can advise him to put the heel outside to prevent any pressure sore, especially in the heel. Then, as we said, for the open fracture, it's require appropriate wound. As we said, it's very common to happen infection and contamination with open fracture due to the mechanism of a blast injury. So the idea to prevent infection, and especially if maybe the wound infected lead to bone infection and osteomyelitis. So we follow COD, wound care, change of dressing, and DBR. Then here about pain care, should check daily and clean 3 times per week, to use normal saline, not betadine, because betadine not used now because it's good media for bacteria. And to clean soft frame 1 time per week. Okay, then avoid tight application of bandages because it affects the venous blood, so it cannot return probably, and it's lead to increased swelling and pain. So we need to be careful to do it firm but not tight, and check regularly, and because it may be lead, as we said, to damage for the blood vessels and also for the nerve. So it should be not tight, just firm, and not to be compressed and not comfortable for the patient. Next, Verena, please. Here also we will continue about nursing. We should, and it's not rule just for the nursing itself, it's rule for all member in the hospital. It's multidisciplinary team, so it's physio with nurse with also patient. He is one part of the rehabilitation process. So patient and family education, it's very important point. So the patient should be aware of own health condition and should be a proactive member in rehabilitation process. He should learn how to move safely and about self-care and even for wound care basic. And about positioning technique, it helps for enhanced wound healing and improve recovery. And as I mentioned, it's not the job of nursing, it's also cooperation with physio and nursing, patient itself, a caregiver. When immobilized, assess it lead to constipation. Patients who stay in bed for a long time may develop constipation because the mobilization less and medication, maybe it's also affects the slow of bowel movement, so it's lead to constipation. So the nursing should monitor bowel habit and encourage a fluid intake and also fiber intake, and promote movement is possible as well. Next point about nutrition and high protein diet to start or enhance wound healing. Good nutrition, we know, help wound healing and bone healing and muscle recovery. And it should be important to advise the patient to eat well and specific type of food like protein, vitamins, iron, and even adequate fluid. It's help. For immobilization patient, they admitted immobilized in the hospital. It's lead for isolated, and the patient also complain from depressed and anxious. So a group therapy or a group activity helps psychological support and motivation. Good physiotherapy with another patient like same diagnosis, so he will encourage and psychological good, and the stress decrease a lot, and social integration. Maybe also we coordinate in these cases with MHPSS They help a lot on dealing with the stress and encourage the patient. Next, please, Verena. Okay. In this slide, I will explain the medical side and psychological MHBSS for the patient in emergency setting. Any fracture it's come with pain, of course. So most of cases complain of pain, and severity of pain, it's depend the patient and the severity of fracture itself. It's come with swelling also and fear from the movement, especially. Manage the pain. We should manage the pain and never ignore the pain or neglect it, because it affects movement and healing, mental health, and early pain management should be to prevent chronic pain and also stress responses and poor recovery. It is not just painkiller. We mean about pain management include a proper positioning, and also to use support for the patient, and also proper immobilization. Maybe also the pain come from bad or improper cast or X-fix. So we need to take the pain in consideration. It's a very important point. We should respect the pain and coordinate with anesthesia doctor, especially before physiotherapy session. We can give the patient pain medication before 30 minutes. It helps increase the pain and suffering from the patient, and so improve cooperation and allow safe movement and rehabilitation. About antibiotic, it's related also to the doctor. It should be carefully used, only just when needed, because overdose from antibiotic may lead to resistance and has another side effect. Okay, in disaster settings, resources limited, so probably given to vulnerable patients, like children and severe injuries are critical patients. So as a priority, we give for children and any critical cases. MHBSS need of the patient and responder. MHBSS not just for the patient, it also for the any health care provider, because we live in the same situation, and the staff may be complaining from burnout. So they need emotional support, group support, communication, and consultation from MHBSS, as well as the patient. MHBSS very important and very essential part of emergency medicine. So it's not like luxury, it's essential to have MHBSS in emergency medicine. Because if the patient motivated and cooperate with the treatment, it will be good recovery, good psychology, and good physically and mental health. Next, please. Here we will talk about communication and rehabilitation after injury. Good communication between all members in the hospital, doctor, nurse, surgeon, MHBSS, physiotherapist, patient itself, the caregiver, family. It's very essential for safe and effective treatment. We can communicate during ground, handover, case discussion, even from documentation. We can read documentation from the doctor or OT note to follow the proper treatment for the patient. Here we will talk about preparedness and how it's help a lot in rehabilitation process. Rehabilitation should start early as possible and be included in emergency planning to ensure faster recovery and decrease disability and better long-term outcomes. Hospitals should prepare equipment in advance, such as crutches, wheelchair, splints. This will improve emergency response efficiency. In the health care workers, especially in emergency situation, should be trained to use and to apply cast, splint, fix, traction in a proper way, because improper use can cause complication and it will be harm for the patient. Here, patients need a regular follow-up to check healing, monitoring complication, adjust rehabilitation plans, and also to improve function and mobility. Follow-up is essential part of recovery. Rehabilitation here should be being as early as possible, day 1 after surgery. It helps prevent complications such as joint stiffness, muscle weakness, and DVT. And we always take into account the patient's previous medical conditions, such as diabetic, because if the patient diabetic, we expect delay healing for cardiac condition, especially special activity, not reach to fatigue, and other pre-existing disability. And we should don't focus only on the primary injury. We should consider or address associated problems. We can take the patient like holistic approach, like chest care. We can treat it or manage it by breathing exercise to prevent pneumonia, and like also edema management. We can treat it by elevation, compression, and movement. We should encourage early mobilization and ambulation. It helps in recovery, as we said, and improve patient emotionally and physically. It's also rule for physiotherapy to check the splints, casts, traction are applied correctly, because incorrect immobilization may cause malunion, deformities, or misalignment in neurovascular complication, as we said, like compartment syndrome or DVT. Or it at least not to stabilize the fracture well, so the bone will heal not in a proper way. Also, we encourage mobility for maintain muscle power and prevent atrophy of the muscle and muscle loss and joint stiffness and contracture by either passive or active exercise and the proper positioning. We should also teach patients how to perform the exercise independently, which is mean patient self-management education. This is very essential, especially in settings like Gaza, where therapy time is limited due to large number of patients and due to also early discharge in high pressure settings. Next, please. Yes, we also encourage for start walking early as much as possible, using walker, crutches, wheelchair, what is possible or suitable for the patient. And in some cases, there is partial weight bearing good if allowed from the doctor. Then always we follow medical instruction regarding, especially regarding traction. We maybe increase or decrease the weight during the case or X-ray, and also according to weight bearing status, and to avoid premature loading and violating surgical protocols. So we should follow surgical protocols and contact directly, coordinate with the doctor and follow the instruction. The primary objective of rehabilitation is to maximize functional outcome and improve postural stability for the patient. So rehabilitation should focus on restoring mobility for daily activities, which can include functional gait training to help patient relearn movement patterns. Here we will talk about important points of a plaster of Paris, BOP. There's advantage and disadvantage. BOP should apply by a trained health care professional. BOP primarily used for a closed fracture once a skilled professional has performed adduction. And it's considered as easy way to apply and require minimal specialized equipment. Cost effective, not expensive, which is make it accessible. And it's just need for BOP rolls, padding, bandages, stockinette, tubular bandage. and it's allow for patient mobile fastly and also out of bed, nor any restriction. And this also allows for early discharge from the hospital. This is about advantage. Disadvantage of BOB, we have also material issue, risk of poor quality of BOB. Some type it's good type, some type quality not too much. It's take time to dry and broken easily, so it's weak and not to protect or stabilize the fracture very well. And also it need larger space, require bulky storage. Physically limitation also, immobilize the joint and provide no access for wound unless a special type like BOB called the bridge. It's have like 3 bars, a medial, lateral, anterior, and we use it sometimes for direct access for the wound. From the disadvantage also, it requires training, like on-job training, and it's effective for teaching, for capacity building for all the team, but it's need time and it's not available in high pressure resources or limited resources or high pressure settings like Gaza. Additionally, it can lead to poor hygiene and physical discomfort from the patient. This is about disadvantage. But I want to add some consideration, especially for a proper application for BOB. Take care when apply it on bony prominence, and BOB should apply not too tight, also not too loose, and put enough cotton padding and ensure not too tight a bandage if we make like back slap. Also, the patient should advise to avoid getting the BOB wet by take shower or put any water and putting anything inside to make like itching. It's maybe lead to sore or infection and contaminated. And we apply it one joint below and one joint above the area of a fracture to stabilize the fracture area very well. And we should check the functional position of the joint and alignment until cast set. And also we should check for pain, especially 24 hours after apply it, and any change in color or sensation. It considers as red flag, and if we see like a change in sensation or color, or he cannot move the tools, it's red flags, and we can immediately remove the cast. Next, please, Verena. Yes, this slide for you, back for Verena now.
Thank you very much, Naveen. So we saw that Naveen told us that a fracture needs to be immobilized one joint above and one joint below the fracture. This is very useful for tibiofibular fractures, for upper limb fractures, but it is very difficult to apply, or it's impossible to apply, nearly impossible, for femur fractures. At the beginning of the talk, we said that the majority of open fractures we get in conflict areas are in lower limbs, and a high percentage of that are femur fractures. We also said that internal fixation is a poor option in conflict zones because of the risk of contamination and infection. So therefore, we have an option of traction. By applying skeletal traction to the tibia, as you can see here in the picture, you align, and hanging a weight at the end of over the bed, you align the femur in a way that it can find its own position and its own alignment. The advantages are that the muscle, because there is a traction over time, the quadriceps, which is one of the biggest muscles in the body, and typically contracting quite strongly in situations of pain, can relax over time and the bones can realign, so we don't have an overlap. We need, however, to be very careful not to apply too much weight. That means that the bone gap is not getting too much. We need to ensure that the bone ends are in contact or just slightly disjointed, but not too much. So the patient, the downside of it is the patient will be more or less immobilized in his bed, means he can sit up and he can move in his bed, but he won't be able to get out of bed. So he will have limited mobilization in bed. In the picture here, you see a specific frame where the femur is lying on the Bowler-Bryan frame, where the femur is lying in and supported from underneath, and the traction puts the bone in alignment. The risks are also muscle weighting, and because the patient has limited mobility within the bed, we need to really carefully check for pressure source and pressure areas on the heel, but also on the buttocks and on the fold of the femur. So in this case, it is very, very important that the patient has a regular exercise routine with and without the physio. Another form of skeletal traction, which can be very useful and is very successful and leads to really nice functional outcomes, is a skeletal traction after a man called Mr. Perkins, where we actually allow the patient to sit up and exercise. You see in this picture that you need to adapt a bed, so the lower part of the bed can be taken away, and you can start introducing knee flexion and active knee extension quite soon after injury. So we typically start 2 to 3 days, or sometimes even before that, depending on the patient, after the traction has been placed. So here the patient can be really, really active. And before, when Naveen talked about the mental health of people who are injured by in conflict, it is quite nice to have a group of people together, and then you can actually exercise them together. Initially, they will start the movement with the physiotherapist, but then we also encourage caretakers and patients for independence, so they can do independent mobilization and activities by themselves. And there it is quite successful if you have a group of them together. So the advantages are that the patient can assume a sitting position, which reduces skin complications and improves vascular and wound healing, because there is some muscle activities and increased blood circulation. You have a knee joint, a range of movement of the knee up to 90, sometimes even more degrees, and to full extension. And the micro movements actually stimulate the callus building in the fracture. However, we know, so within the ICRC, we use this technique and we promote this technique a lot, but we know that people are often a little bit skeptical, because the treatment with the definite treatment with traction will take up to 6 to 8 weeks, which is a long time when you need to free up beds. So recently in Gaza, what we have been doing is we have been using the traction as a temporary treatment till the wound is healed and closed and well, and then refer the patient on for intermedial nails for internal fixation. I hand back to Naveen.
Thank you, Verena. In this slide, we will explain about important point for external fixator to know about advantage and disadvantage to use XFix. About advantage of XFix, it's fast to set up, especially in emergency or trauma situation. Another point, it's also effective for stabilizing bone fractures. And it's also allow to treat soft tissue injury or wound easily. And also it does not require large incisions, so it's minimal invasive technique at the fracture site. And also it can be used as either temporary or final or definitive treatment. It's strong also enough to allow the patient to start put with bearing on the limb or loading, according also to the doctor instruction or progress in the X-ray. About this advantage of external fixation, the frame itself heavy and physically large outside the body, so the patient not comfortable. Second point about bacteria can enter through the bin site, and so it's high risk of infection. We called it bin site infection. It's common with external fixation. And also another point about over the time, the bins itself holding the bone from inside, it can become loose. So dynamization can help to solve this problem. The doctor can make it in OT and start to make dynamize for the roots itself and make the bone near together, so it's a start callus formation and start healing of the bone. Neurovascular injury, it's very common with external fixator and potentially injury for blood vessels and damage for the nerves. It's happen during a placement of XFix. Muscle like immobilized lead to stiff in the joint and tight of muscle due to immobilization for at the first time, and soft tissue contractures may also happen due to immobilization as permanent. Next, please. In this slide, we will talk about BOP and external fixator general care. It is very crucial for monitoring the patient closely for the first day after applying a BOP cast, as we said, to check for any circular issue or swelling and to take direct action, immediately action to remove it if we see any complication or any warning sign or red flags, we can say. Next point about patient shouldn't submerge or bathing the affected limb in the water, but he can or should maintain personal hygiene through a sponge or careful washing of the limb. And in generally, patients with these XFix require hospital monitoring and shouldn't be sent home immediately until they are stable. So we encourage the patient to stay in the hospital, but also because of overpressure settings or the capacity of the hospital not allowed. So we can discharge the patient, but we need to require discharge safely for the patient. Then teaching both patient and their family how to manage the XFix and recognize warning sign is vital point before they go home. So we can inform the patient about any sudden symptoms they can or warning sign can come back for ED, and the doctor will deal with that. Regular also medical check-up as the follow-up for removal, maybe for the XFix or follow. Also, it's should be considered and scheduled to monitor healing and eventually maybe remove the cast or external fixator safely. Last point in this slide, they talk about primary goals of rehabilitation should be the patient's ability to use their limb and perform ADL, activity of daily living, rather than just looking at the bone alignment in the X-ray. Back to you, Verena.
Thank you, Naveen. So fractures obviously have complications. One of the major complications are nerve injuries. So it is quite important, or it's very important, that this is assessed as early as possible. When a patient is in a cast, a circular cast, this is obviously much more difficult, but it's the physiotherapist's task to check for muscle activity or to check for nerve injuries, to ensure that this is addressed as early as possible as well. When a patient is immobilized, one of the major complications are thrombosis, and therefore prophylaxis is the key. We talked about the importance of getting the patient out of bed and mobilizing as early as possible, and that is the best prophylaxis we can do. We also talked about the complication of compartment syndrome, and that is that compartment syndrome requires immediate intervention, and most often surgical intervention. This is specifically important for crush injuries where bleeding keeps happening when the tissue is damaged. So it's very important that this is addressed quickly and, if possible, within the first 6 hours to avoid permanent damage of the nerves. Pressure ulcers are also a big complication. Here we need to be careful when we have a patient who is immobile in bed, but also we need to make sure that we don't create pressure areas when we apply plaster of Paris, particularly circular plaster of Paris, or even back slabs in the initial phase of treatment. We just need to make sure that bony parts and sensitive parts of the bodies are well padded. One thing we maybe didn't talk so much, in MCIs, we don't do back slabs. We immobilize the fractures with Kramer splints till the patient can go to OT for the very temporary solution. And here it is quite important that we put enough padding, that we pre-prepare the splints with padding to ensure that we don't create pressure sores, even if the patient is waiting for only a few hours to go to OT. The major complication of fractures in conflict settings is, as we've mentioned a lot of time up to now, infection. And as Naveen said, this infection prevention is a multidisciplinary duty, and it includes the whole team who works with the patient, and also, very importantly, the patient and the caregivers themselves. When we looked at traction, at the traction pictures, we typically say it's about 10% of the body weight of a patient, that we put the traction weight is about 10% of the body weight. This is, of course, quite difficult to be accurate about. Sometimes we may need a little bit more, sometimes we may need a little bit less, depending on the soft tissue injury of the quadriceps. Here it is very important that we don't put too much weight on, so we stop the wound healing. Because one of the big problems of fracture management in conflict situations of conflict is the malunion. So we have it's very important to do a regular monitoring on X-ray to ensure that we have a callus formation and we are on the right track. In terms of functionality, one of the major goals, as we said before, is functionality and is including the mobilization or the function of all range of movement of the limbs of the joints. So having a good program, a good home program, and also a good in-hospital program to mobilize the joints and to stimulate the function is essential. I hand back to you, Naveen, for the challenges.
Thanks, Verena. Here we will talk about critical challenges in rehabilitation within complex environment. The first challenges is about accessibility. Accessibility to basic material is limited and severely restricted in conflict areas, especially in like crisis setting like Gaza. This basic material like assistive device, wheelchair, and BOB, traction set, and other equipment necessary for physiotherapy. Second challenge is about challenging environment. We know the infrastructure damage, so we have infrastructure issue, restricted access to essential utilities like electricity and water. The third point about bullet trauma and complication. We see a lot of cases in the war, especially. So the complex of the case, clinical complexity, management of bullet trauma and associated complication, and the risks posed by late referral and infection. So we not see just a fracture case. The case is very complex, a fracture with also amputation, with visceral problems or organ, kidney, all affected. So it make the rehabilitation also difficult, not easy. Another point about team coordination, the need of IDT, interdisciplinary approach or team discussion to determine all about the patient and weight bearings protocols. It should be discussed in interdisciplinary team and determine about weight bearing status and all update information for the patient, which is not available in complex environment like Gaza because the high pressure context, and also there is no time limited due to a lot of MCIs, mass casualties incidents, and it's massive, a large number of patients, and the capacity of the field hospital not allowed to deal with all that's a large number of patients. And also some issues with discharge pressures, issues surrounding the patient to being discharged too early or before definitive treatment is complete. As we said, due to capacity and also due to high pressure contacts a lot of patients, so encourage for early discharge of the patient, and a lot of admission or casualties enter the hospital with also complex and severe polytrauma. And about last point about safety requirements, the necessity for a rehabilitation professional to ensure the safe discharge through the provision of splint, cast, and assistive technology. It's essential in rehabilitation to discharge the patient safe. Next, please. In this slide, we will explain about several key barriers to effective rehabilitation and patient care. About professional and clinical gaps, lack of training, and the staff not be trained in managing traction, X-fix, BOB. So if not trained the staff very well, the treatment will be harm for the patient. So we should train an ICRC protocol for management of fracture and others disease or other trauma cases. Second point about inadequate interdisciplinary approach or communication and collaboration. IDT issue or interdisciplinary team approach issue maybe lead also to make like confused and not to take the decision. Inadequate collaboration and communication between different medical specialists, it's also affect the rehabilitation process. So coordination, it should be necessary between doctor, nurse, and physiotherapist and surgeon to take the decision and be in the same line. For example, if we say the surgeon decide for something and there is no coordination between physiotherapists, it may be lead to harmful procedure from physiotherapy, and he doesn't know about the instruction or update from the doctor. So we should coordinate together as one team to give the patient optimal care. And about another issue or challenges about changing a protocol. Protocol not constant, so challenges caused by using various or frequent changing clinical protocol. It's lead to confusion for us and for the patient also, because it's difficult to assess also the outcome measure because no standardized for the protocol. In conflict in environment injuries, not only physically, the patient comes with also severe psychological trauma. So the absence of support and MHBSS leave the patient unable to engage effectively with the physical or medical treatment. So if the patient refuses medication and patient session, and he not take psychological support well and MHBSS, it will lead to complication and failure even in entire rehabilitation process. So it's essential to comprehend MHBSS for all the patient with coordination also with physiotherapy. We will talk about difficult access for follow-up care. Medical care is a chain of follow-ups. It's not just one point. In the war, this chain may be broken due to destroyed droids and high risk of travel. So it's prevent medical staff to monitor and detect infection early, which can lead to life-threatening complication, like the patient with, say, X-fix cannot come to the hospital due to maybe checkpoints or shelling, any other or safety issues may lead to bin site infection and then converted to osteomyelitis. When the patient discharged and he live far from the hospital, so it's affect also the follow-up, and the patient needs safe and clean environment. But in Gaza conflict, the patient discharged and returning to the tent or destroyed home, a lot of obstacles prevent the use also for say a wheelchair. It may also expose the patient to fall or any infection. And for example, also a patient with spinal cord injury live in say like a third apartment, lead also to lack of mobility and maybe lead to another complication or secondary complication like bed sore. So we should educate the family and caregiver, because family factors, it's a significant, it can be like help the patient or worse the patient. It's significant barriers if the absence of caregiver or a lack of education. So the family and the patient not help us in the rehabilitation process. So we should educate the patient and caregiver for proper care at home, especially with the patient who say lost the family, so he need to see someone to take care about him, especially if he has severe polytrauma complex. It's not easy to get back for function or EDL or social communication easily. So also it's challenging. Next, Verena, please. Here we will talk about essential protocol for medical professionals, especially during mass casualties incidents. Here I will explain the key points. First of all, management and support priorities. In a conflict or a crisis, a structured hierarchy is vital to ensure the most effective response of the priorities as follows. We should follow the order. Command lead, establishing a clear chain of command so everyone knows who is in charge, who is responsible for what. Second, things about safety. We should ensure the place safe for both patient and responders before proceeding any procedure or any intervention. Second point about communication, we should maintaining clear lines of contact between teams and hospitals to make the work easy and everything's be coordinating. Assessment and triage, rapidly evaluating patient to prioritize those who need immediate life-saving care and who can wait. So fast screening, then immediate intervention for the patient or anyone need for a quick intervention. Treatment and transport, providing necessary stabilization or like first aid, and then transfer the patient to suitable or appropriate medical facility. Should not be compromised or reduced also, because in high pressure environment, it like aquatic or high pressure environment, so the standard of care should not be compromised or reduced. So we should emphasize avoiding neglecting or ignoring clinical details due to high number of patients. So we should focus on quality of service and the standard of care, and also to share with others a treatment. Here we will talk about a clear communication and instruction is required when a patient leaves the triage or a treatment area. This indicates maybe about medication, accurate instruction, what to take and when, and also about risk of complication, warning sign that indicate the patient condition might be worse, and about also exercise and referral point for giving instruction and guidance for physical rehabilitation or referral to appropriate follow-up care. So the patient should inform where to go as follow-up care. Back to you, Verena.
Thank you, Naveen. So we're coming to the end of our presentation, and our key messages are that in a global emergency response, the emergency response shapes the treatment we can provide. We need to have a flexibility and adapt as necessary to the conditions where we and the patient finds themselves in. Fractures are very prevalent in conflict and disasters, but they are seldom the only injury. They're most often in a combination with other injuries. From a surgical point of view, it is crucially important that debridement is done before definite application of proper immobilization, because infection will stop the consolidation of the fracture and might lead to complications such as osteomyelitis. Clinical and X-ray follow-up is required to ensure a good consolidation, and non-well-treated fractures can lead to lifelong disability. As a rehabilitation workforce, we need to be trained in correctly managing immobilization techniques. Thank you very much. Now I think we come to the questions.
Yes, can I? So thank you so much, Verena and Naveen, for this very interesting presentations. We have a lot of questions and answers, and since time is running as well, I did choose some of them, and well, after you can decide who wants to answer them. So the first question is, in providing rehab care for patients who sustained fracture in conflict areas, one of our priority as PT or rehab professional is early mobilization and/or loading. In collaborative care, where other professionals from other disciplines clash with our aforementioned goal or priority, how do we address this difference in perspective priority? Verena or Naveen, I kindly ask you to respond.
Thank you. I mean, this is a very, very big question. Obviously, I think one of the things, not only working in conflict, but working generally with a severely injured patient, is good communication. And I think the interdisciplinary approach to patient treatment, not only for fractures, but also for other war-related injuries, is absolutely crucial. And I think if you are given the opportunity to take part in a ward round, this would be the best option, or in a patient discussion, that you have a regular weekly update where a patient is discussed either at the bedside, or ideally, if there is a conflict, in an extra meeting, to have a common understanding of why we are trying to do early loading. As you say, it's sometimes we are not allowed to do early loading, particularly with X-fixes, when the fracture is very comminuted and very unstable. We are then asked to wait with the weight bearing till there is some sort of stability and some sort of more definite treatment available. So I'm not quite sure. I hope I have answered your question, but I think the key for me would be in good communication amongst all team members who are caring for the patient. I don't know, Naveen, do you want to add anything to that?
Yes, I agree with you, Verena, totally. I also advise for communication, and as we mentioned, communication and communication and communication. It helps a lot in rehabilitation. So all of us know our rules and when to do our intervention, and also to work together like teamwork, and it will be a benefit for the patient.
Thank you.
Thank you very much. I also totally agree with the two of you. Next question is from Rava Adam, and it's the following. based on your experience managing different types of fractures in conflict and disaster setting, I would like some general advice on managing joint stiffness resulting from prolonged immobilization, especially in the complete absence of physiotherapy services as part of the emergency medical response. General advice on managing joint stiffness is a big one as well. Naveen, you want to start?
Okay. About joint stiffness, we encourage as much as possible early mobilization, which is mean not just walking, which is mean we can start for positioning in the bed and mobility exercise in the bed, and we can start if the patient not able for walk or the doctor not allowed for weight bearing, we can start early as much as possible exercise in the bed, and also range of motion. Try to keep range of motion, try to keep or maintain muscle power. We can start like isometric exercise and slowly exercise active as much as the patient can. If he cannot do active, we can do passive exercise as much as possible. So, and not just the patient wait for physiotherapy session. He can do also, we can teach the patient. It's also a very crucial or essential part for, as we said, family education. They can follow during the patient in the hospital. They can also repeat exercise and not just depend or rely on physiotherapy, because they are part of rehabilitation. So as much as we start exercise, we prevent joint stiffness and other complications.
Thank you.
Thank you, Naveen. I think just to add that it will, of course, mean that we have to balance the immobilization of the limb, which is fractured, with and the stability of the fracture with the mobilizing of the joints which we have available. So we were saying when we apply, let's say, plaster of Paris, we have to immobilize the joint below and the joint above the fracture, and this is due to the muscles, particularly the muscles who go over the joint. But it is always a good idea when we do apply a plaster of Paris in particular, that we discuss with the surgeon if there is an option to reduce the length of the cast as much as possible, so we can actually mobilize as many joints as possible. So an example here would be a practical example. If we have a distal tibia fracture, we might be, which is a stable distal tibia fracture, we might be able to not immobilize the knee. Whereas if we have a mid-shaft tibia fracture, we definitively need to go with the cast above the knee to immobilize the knee to stabilize the fracture. But that is another option. And I think the key, as Naveen said, the key to it is to involve the family and the patient themselves to get as active as possible. But of course, if there is no rehabilitation services available, as we know in many situations, this is certainly a very big challenge.
Thank you, Verena and Naveen. So we are going to our last question live, which doesn't mean that we will not try to answer all the other questions. We will. So last live question is the following. In areas of conflict, we may presume that patients, particularly children, who sustain fracture can be secondary to blasts, may not just be physical traumatized, but also emotional. This can lead them to avoid movement as physical pain may apply emotional pain. How can we address this? How can we encourage the patients that early mobilization can help them to recover quicker? Verena.
Thank you very much. That is another very good and very relevant question. I think, I mean, in children, mobilizing children who are traumatized, either physically and or emotionally, is very, very difficult. We try, that's why we very strongly advocate to have mental health support as well in parallel to physical rehabilitation. So we can do it in a transdisciplinary way, to do activities in transdisciplinary ways. From my experience, the easiest way is to play, to be playful, to distract the child from the actual activity we want them to do. And that is where the MHPSS team can be very, very useful. They can, let's say they can do a drawing activity or a specific activity with the child, which allows us to do our work either covertly while they're doing something else, or we try to choose a joint activity with the MHPSS team, who is not so threatening as the physios might be, and choose an activity where we can incorporate flexion extension of, let's say, the elbow of the upper limb into the activity. I think it is a challenge. Children are always a challenge, but staying playful and be creative. And also often we may not be able to touch the child, let's say, for passive range of movement, in which case it is more successful to instruct the caregiver who is with the child to do that activity, and we can just monitor and help them to do it, but we may not be able to physically touch the child ourselves. Naveen, do you have any add to that, or?
I definitely agree with you, Verena. It's a very big challenge to deal with children, especially zone. They are already exposure to very difficult situation, physically and also emotionally. They exposed to trauma. So it's need a patient from us and to start to respect the pain. And if he complain from the pain, if he refuse the session from the pain, we can coordinate with anesthesia and give him any painkillers before physiotherapy session. So and start gradually. And as I said, to be patient, start gradually exercise, coordinate with pain anesthesia, painkiller, and also to encourage him. Maybe we use toys or distraction, any other modalities like playing therapy, and maybe we encourage him with group physiotherapy like peer. And also, as you mentioned, IDT, interdisciplinary team, coordinate also with MHPSS, but again, it's difficult, especially children, the cognitive level, not too much to understand all the exercise. So we use and create, to be creative, initiative for another modalities or technique, not like as we deal with elderly or adult people.
I think that brings us to the end of the time. So I don't know, Chloe, did you want to close?
Yes, absolutely. Thank you so much to everyone who has joined us today. We hope you found it a very informative and engaging session. We would welcome you to use the link in the chat to join us for the next session on Thursday, the 21st of May, which focuses on peripheral nerve injury in conflict settings. I'd just like to take a moment to thank our speakers, so Verena, Naveen, and Martina, who has been in the background answering questions in the Q&A. Thanks again to Pete, and the World Physiotherapy team for putting this together and supporting the
Thank
delivery.
you.
Thank you very much. Also, a big shout out to our interpreters, Inaya and Roxanne, who have been doing a fantastic job with the Arabic interpretation. Thank you again for joining us. I wish you all a wonderful evening, morning, or day, wherever you are in the world. Take care.